All right. So first of all, I'd like to thank some of the two individuals who usually help me put this course on. It's a course speech that we give at the Academy, the U.S. Academy, that focuses on medical legal issues in endoscopic sinus surgery. It came up because one of the past chairmen of the Academy had a really bad complication with his endoscopic procedures, and he said, hey, why don't we start doing courses that look at complications of endoscopic sinus surgery? The first few years that we gave the course, there were over 100 people in the audience, and then I just got emails after emails after emails. And then I started to do medical legal reviews, mostly for defending physicians with patients in this situation. And then in the Bay Area, I became known for defending patients in this situation or representing patients. So I'd like to start off, how many of us are practicing general ENTs who've been in practice for more than 5 years, 10 years, 15 years, 20 years? I say I'll keep my hand up because, okay, good. So a lot of experienced physicians here. And I'm going to let the talk be fairly general and allow time for you to ask me questions. And just realize that this doesn't apply to endoscopic sinus surgery also, but you can hopefully take some of these tools back for your tonsil cases, for your parotid cases, for your other procedures. It's going to have a patient slant to it, obviously, with some of these objectives. Key one that most of us still don't think about is the informed consent procedure. And there are very few lawsuits concerning informed consent. But there are a lot of lawsuit components where the patient will say, you know, I didn't know that was going to happen. Nobody told me that. I didn't understand that. I wasn't aware of that. And that points back not to just informed consent, but how we communicate with our patients. So I'll touch on informed consent. I'll touch on the difficult patient, some of the key advice points from a malpractice lawyer who I usually do these cases with, and then hopefully time for open discussion. We'll focus on also teamwork, how to deal with the upset or disgruntled patient. I'll touch on documentation, and then I'll also try to bring up how to say you're sorry or to disclose a complication to a patient. I don't think that was me. Was that me? Okay. Let's see if I can do this without going too fast. All right. Not taught in med schools, most med schools. You start practicing, and on average, it's usually about your 5th year in practice that you'll get a letter that just stresses the hell out of you. It's a letter that just creates heartburn. You open it up and you go, okay, here we go. And that will take 3 to 5 years to go through. Most lawsuits are not solved within a year or two. And it's from not only your standpoint, but your partner's standpoint. You take the stress home with you. The patient's doing the same thing with their job, their partners. It's just this, it's like a bad divorce where everybody's all just messed up for a period of time. What do you do with this situation? I'm going to give you some guidance and some thought processes. So here's a patient who was referred to me who walks in, he says, I didn't know this could happen. I had endoscopic sinus surgery about 20 miles from where I practice, and nobody told him he could have had a CSF leak. He had the surgery, had a CSF leak. He's a pilot for United, couldn't fly for a year and a half, affected his income, affected his life. And eventually, with the repair, he lost his sense of smell during the repair surgery. Going through his records, nowhere was he ever explained that this was a potential complication. And I asked him, I said, would you still have had the surgery? And he says, yeah, I would have had the surgery, but probably would have done more medical management, probably would have sought 3 or 4 opinions, probably would have looked around for physicians who are using advanced technology. But he still would have had the surgery. This is the complication that is the most significant complication, I think, in endoscopic sinus surgery. CSF leaks we can repair. They're not hard to fix. They really are not hard to fix. They trigger a lot of anxiety. But this complication, the medial rectus versus the endoscopic shaver, is one that cannot be fixed and is one that the patient presents to Walmart, to Safeway, and their kindergarten teacher, and everybody looks at the patient and says, "What happened?" And the patient's response is, "Oh, I had sinus surgery with Dr. Vaughan." CSF leak you can hide, you can patch it, it's in the brain. But this complication is one that is a really hard one. And so if you do the laboratory, or if you go back to your practices, think about the medial rectus muscle more than the brain. And in the laboratory today or tomorrow, whenever we do it, find the medial rectus muscle. If you can't find it, ask one of us to come over and show it to you. Every CT scan you should look at, normal, abnormal, look for the medial rectus muscle, look for the anterior ethmoid artery, look at the shape of the skull base. But this is my key factor in risk management for endoscopic sinus surgery for you today, medial rectus muscle. I have been unable to successfully work with a patient and their lawyers when this happens, because if I look at you and one eye moves the opposite direction, it's really hard to say this is an expected or unexpected outcome or a complication. And it usually is shaver-induced. Aim in the shaver towards the eye during endoscopic sinus surgery, similar mucosal removal from your case. You can just lift off everything else that's there. These shavers are super strong, and now we attach them to huge suction machines that suck at 600 negative pressures, and to aim that shaver at the medial orbital wall. Think about it. Suggestions when you're in the posterior ethmoids, use a mushroom punch to dissect out the posterior ethmoid bony walls. As you go deeper into the ethmoid cavity, the space narrows and the medial rectus starts to come in towards you. Turn the shaver off, turn it down, or use it vertical, but don't go against the medial orbital wall and say, there's that polyp that I want to go after. So think about other ways to approach it. Malpractice and complications are two different things, and sometimes they cross over to each other, and that's when it becomes a problem. Most complications are not malpractice. And what is a complication of surgery? A complication of surgery, in my definition, is something that pisses the patient off. Not sure if we can curse in Seattle, but I just did. So if you think of it that way, and now with social media and Yelp and your medical board and your hospital board, a complication is just a total headache. And so think of that group of not just what we've seen Dr. Stanquist publish concerning complications, but things that are going to lead to you just having the need to take Ambien that night when you get home. It usually is a bad outcome that has led to a significantly bad outcome for the patient. That then leads to a miscommunication that then leads to the elected individual being brought in. And that elected individual could be a lawyer, could be our hospital compliance group, could be OSHA, could be our medical board in California that is asked to basically come and say, is this physician, he or she, negligent in their behavior? And to prove that a complication is negligence requires several things, obviously. You have to have been their surgeon. If you weren't their surgeon, you're out of the door. So proximity, you did something to them. That something led to this complication, this problem. And then there were damages that were future damages, actual damages. Was there pain and suffering involved? It's not a great way for me to start the course for you, right? So let's talk about a regular case, a true case that actually came in to see us. Sinus surgery, no complications, went home, had some bleed-in, returned to see his ENT 3 days after surgery for bleed-in and severe headaches. So you shouldn't have bleed-in at 3 days after sinus surgery. Very few people are bleeding after 3 days. They may be oozing, so you ask, is it teaspoons, tablespoons, or cups full? First day, a few tablespoons. Second day, a few teaspoons. Third or fourth day after sinus surgery, people should say, I kind of just have a little bit of globs of mucus. But bleeding 3 days after sinus surgery is concerning. Same thing for severe headaches. A day or two after sinus surgery headaches, but if somebody is still on a narcotic pain medicines 4 or 5 days after sinus surgery, probably something not really going right. whether it's an infection, a lot of packing stuck in the sinus cavities, old blood in the sphenoid sinuses, air in the brain, a bleeding issue, something's wrong at that point. This patient came in, saw the ENT physician, got cleaned out, got a repeat packing, went home, and then 7 days later, while showering, had a grand mal seizure, fell and hit his head in the toilet. His wife dragged him to the local emergency room, and a CT scan was done. The emergency room doctor brought the wife into the CT room and said this was the time when you would go back to the CT room pre-COVID, and everybody was all over the place, and showed the wife the patient images and said, this is why your husband has to be transferred away from our small medical center to a bigger medical center, because he has a little bit of a problem that we can't manage here after his sinus surgery. And this is, I call it the tornado sign. I mean, this is when you know something really went bad. And you can see what that shape is. This was the first year that the curved endoscopic shaver blades were introduced, right? And so an angled blade where you can't see the tip of it with a straight scope is a dangerous instrument. An angled blade requires an angled scope to monitor the full extent of the blade. Putting a blade into the maxillary sinus and turning it on and shaving away the infraorbital nerve, putting a blade against the skull base and not being able to see it. So this was the first year where the shaver blades that were angled were introduced. And if you look at this patient, he has suffered a skull base injury, a brain biopsy, an orbital injury, and bilateral anterior ethmoid artery transections, right? So his pathology is significant. And could this have happened to any of us? We say no, it couldn't happen to us. But if you had a bad day, you had the wrong images up, you were not thinking straight, could this have happened to you? And yes, this happens to very good surgeons, where we get lost or we get disoriented or we are tired at the end of the day, 3 cases in, and this happens during a sinus surgery, a parotid, a tonsil. We're human. The patient started with postnasal discharge. His postoperative complications included anger management. He developed a psychiatric self-control post-traumatic disorder, just kept on going downhill. I followed him for 20 years. He remained in my practice for 20 years. I did his repair or attempted repair. Some of these things you can't repair. Led to a divorce. His life just didn't go well after this traumatic episode. And it was an extended lawsuit. And in the end, I thought about him and I have had the chance to think about him for many years. And I think what happened with him was that it was a new technology, a new tool for the wrong disease process. He didn't have frontal sinuses. There was no frontal sinuses on his anatomy. But the surgeon thought there were, and he or she were looking for the frontal sinuses. So as technology comes out and we ask about image guidance, we ask about shavers, we ask about balloons, think about the technology and definitely come to a course like this when new technology comes out. Play with that new technology, whether it's something as simple as a device to balloon something or to radio frequency something. Make sure you have a fairly good usage of it. We have industry here in the room, and it's industry's role to sell and for us to use their tools once they've sold them. But before you use their tools, think about ways in which those tools are going to be useful to your patients, but also how those tools could be harmful for your patients. I'm going to skip through in terms of time. When a malpractice issue or a complaint arises, usually there are multiple components to the complaint, from negligence to failure to diagnose, sometimes unnecessary surgery, and hopefully not wrongful death. This combination will therefore lead to you needing to do a lot of things. And again, it will occur all throughout ENT, not just during FES. FES became the winner in medical legal cases for quite some time. Fortunately, it's going down and facial plastics is climbing, so that's a great thing not to be a facial plastic surgeon. But FES, at one period of time, and this was probably about 8 years ago, represented 70% of otolaryngology claims. It's about 50% now. So what you're doing here, I congratulate you for coming to a course like this, because hopefully you're going to be aware of these data and be aware of how we can avoid some of these things. Informed consent, I'm going to skip through this quickly, but the one thing I'm going to say is please schedule a separate visit for a preoperative counseling visit for every single patient you have. To say to a patient, you need to have a tonsillectomy, have your surgical scheduler meet with the patient, and then the next time you see them is in the operating room, is asking for trouble. The same thing for FES, the same thing for parotids, the same thing for facelift. I suggest that you schedule a preoperative visit 3 to 4 days before the surgery with your patient, and that you spend 20 minutes with the patient and a family member, and you spend time talking about the surgery. This is the fastest way to reduce your surgical risk and your malpractice risk, is a separate level 4 clinic visit 3 days before the surgical appointment. Gives you time to talk. You'll get to meet the family, you'll get to review the CT scan, and you'll focus on educating the patient, family member, talking about reasonable expectations. It will also allow you to say, these little ethmoid bones, when you're reviewing the CT scan, I'm going to remove. And if the patient turns to you and say, you're going to remove bones from my head, it really reminds you why you need to do a separate pre-op visit. This is your tonsil, and this is the vessel that lives next to the tonsil. It's called the carotid. It goes from your heart to your brain. This is your parotid gland, and this is the facial nerve, and you may look like this after surgery. And if you do that 4 days before surgery, 1, you can bill for it. 2, you're going to realize that the patient has been educated. And 3, hopefully the patient and the family are fully aware of the journey they're going on, so that in the post-operative period, they are just as educated as you, and their expectations are just as simple as you. Schedule separate preoperative visits with every single surgical patient. If you're doing 100 patients a week, you're lucky. You can hopefully find 12 other people to do those pre-ops for you that are other surgeons that have retired. But if you're doing 12 surgeries a week, think about bringing those patients in at the end of your day or at a time where you can spend time educating them. And have tons of handouts, devices, educational tools. For FES, the easiest educational tool is to open the patient's CT scans, sit down and say, this is your anterior ethmoid artery, and they'll say, what's that? And you say, it's the artery that goes from the brain, crosses over through the sinuses into the eye, and puts you at risk for an orbital bleed, intracranial bleed, and CSF leak. If I hit that at the same time, I'm dissecting out the ethmoid cell. Okay, and again, your video, you showed a great example of bilateral anterior ethmoid arteries. As soon as I saw that CT scan, I was like, that's the patient for an informed consent visit. You don't want a patient to say, why is my eye swollen after sinus surgery and I can't see out of it? It's just something they should say, I know what you're talking about. So patient education, absolutely appropriate, required, strong advice point. The dissatisfied patient. Who's had a dissatisfied patient this week? This month? All right. Who is brave enough to talk about their dissatisfied patient? Go for it.
I have a patient who had very good surgery previously, did very well. I have a patient who, this is making a difference, who had a very good surgery, did very well, and then unfortunately blocked off her frontal and got a supraorbital fluid collection. It got drained by our ophthalmologist. She has about a 3 millimeter frontal, and so she needed to have a Lothrop procedure or a draft 2B, which was done. Her surgeries have all gone very well, but what she doesn't like is having to work with a team, and fires a lot of the nurses, fires a lot of our support staff, is very difficult to work for. And so unfortunately, we've had a lot of challenges, not because of the surgery, but actually because the patient doesn't want to work with anybody. So I've had to go personally talk with her and work with her a lot. We've had our our legal team involved and our patient relations team involved to try to help get her the appropriate care. So actually, from a surgical standpoint, she's doing great. But from a patient care standpoint, she's not. So I don't know if other people experience that, but that has been a real challenge for us in the tertiary care world.
That's a great comment. So the patient who you just can't make happy, and that's usually your mother-in-law, that's usually your father-in-law, and unfortunately, we all have those patients. And that patient comes in my schedule only at one time slot. So when you open that patient's Epic screen as a scheduler, they have a little note right next to it that pops up as WV only. That's my initials. And there's only one WV only slot on my schedule. And it's usually Thursdays at 3:30 because I don't have to be anywhere on Thursday evenings. And so that patient will come in at Thursday at 3:30. All my staff are done and gone, except for my nurse practitioner. And Kathleen will scribe, and I will talk, and I will drink water. And if it gets really long, I will get up and I'll say, we're done for today. I need you to email me the 27 other questions you have so I can review them this weekend, and we'll meet next week, Thursday. And you wish you could just turf them to another physician, but that usually increases the patient's anger level and triggers a sense of abandonment. But you'll find that patient, you're just going to have to work through them. Your staff know who those people are, and I can tell you your staff should tell you who those people are, because quite often the staff will tell you, yeah, that person's been really rude to me. Right, at check-in, you'll hear them talking about, why do I have to pay the copay? You guys made a $20,000 bill on me already. Why am I paying for this copay? So that patient exists for all of us. Try to think about how to approach that patient and how to treat that patient. Some other caution areas, image reversal, and not remembering which side had which sinusitis. I think one of the nicest things about an image guidance system is that you've got the images right there in front of you, but you can take notes on a 3x5 card, draw a line down it, and say, this is the left side, this is the right side, this is what I need to accomplish for each side, and go through it. Other things to look for, unrealistic expectations, as we spoke about, the rude or inappropriate patient. And the inappropriate patient can be highly inappropriate. And in today's world, we as physicians have to remind our staff members to tell us when that patient touches them, when that patients look at them in a certain way. In today's society, that inappropriate patient needs to be retrained rapidly by the physicians, male, female, gay or straight, transgender within your community. Rapidly retrain that patient because they need to be appropriate to your staff and appropriate to you. Documentation. We all hate Epic. We all hate our EMRs. Some of the key tools for documentations also are diagrams, and you will see this in otology practices where they'll draw things. Think about doing that in rhinology, where you draw things, draw the CT scans, take pictures of things and bring them into your EMR. You should always have one line, no matter who documents for you, nurse and staff, residence fellow, where when I open up that note, I can see, oh, that's the line that, the doctor actually who saw the patient wrote, because it gives the flavor of the practice. EMRs auto-populate, and the auto-population becomes really easy for lawyers to realize that you're actually not really documenting, you're just billing. And so when an EMR system becomes a billing system only in your practice, you want to think about ways in which you could choose to change it, whether it's by dictations or dictating later at night or having your medical assistants become better scribes. That is another key advice point. Medical assistants are not only in your practices to room patients and take vital signs. Hopefully, when you leave this course, all of your medical assistants will be able to sit at the EMR and scribe when you're talking to a patient. Dr. Vaughan told Mrs. Jones that she has an exposed anterior ethmoid artery. During his visit with her, he also showed her the medial orbital wall and explained that bony walls will be removed during endoscopic sinus surgery. Signed, CC.MA. And then when I read through that note at the end of the day and I sign that note, I'll edit that medical assistant's note and change things. So I hope your medical assistants, how many medical assistants scribe in your practices? Why don't they scribe in your practices? Is it your hospital systems say they're not allowed to scribe, or they don't know how to use the EMR? They're usually in the hallway talking with their friends, is the honest truth. Or you don't trust them to scribe, or you didn't hire them at a high enough level. So the medical assistants you have now, in the employment market that we have, hopefully in a year they'll be able to scribe. Or in a year from now, when those medical assistants, male, female, or not, are no longer in your practice, your newer medical assistants will come with scribe skills, where they can actually scribe and type for you super fast, okay? I'm almost finished. For the EMR system, late entries are really dangerous, and so if you're putting something in later on, put the time next to that note so everybody knows when you put that in. Same thing for missed appointments or canceled appointments. We want to make sure that that's documented somewhere, hopefully by the front desk, and that you get notified of that these 3 patients on your schedule didn't show up, and you could say, oh, I really don't need to see them. They're on their topical nasal steroid sprays. Or no, I should have seen that patient. That's an inverting papilloma that I haven't seen for 3 years. I'm gonna skip through late entry and EMRs all right, so on your way home, I'm going to ask you to think about your clinic. Hopefully you'll think about your medical assistants, your staff. I'm going to ask you to think about your surgery center. What do you do there? What do you do there? And what do you like doing there? I operate at 2 places currently. One, a university hospital, where I cannot choose who I operate with in terms of the nursing staff. And quite often they change every 20 minutes during a long procedure. So I'll be operating and just things are happening over here and people vanished. I'm like, where did that person go? And then a new person comes in, I ask for a frontal sinus seeker, and they'll go, oh, hold on, let me go looking for it. And I say, I didn't ask you to seek for it. I asked for a frontal sinus seeker. So that's a really frustrating place to operate on. That's where I do some of my simplest cases at the university hospital. Why at the surgery center, where I really should be doing my easy cases, is where I take my hard cases to. Because when a scrub tech scrubs in at the surgery center with me, they stay for the whole case. They are there, they know the instruments, and when a new scrub tech comes in, they spend 30 minutes doing a transition, so I'm really comfortable doing my very hard cases at the surgery center. When I go to the university center, I only take 1 hard case a day there, and I make it the last case of the day. By the time I've been there for about 3 hours, I've figured out who the good staff are that day, and I'll go and beg that person to come back for my last case. I'll say, I know you're here. Can you make sure you don't do the urology across the room, but you come back to my last case? And I'll orientate that person before the case. I'll review the scans with them. I'll tell them this is our aim, this is our goals. You would do the same thing with residents or fellows. You should do the same thing with your surgery techs. Practice as both a surgeon and as a physician, but practice also, when you go back and you leave here, as a patient. And quite often when I do malpractice lawsuits with a very angry patient, the one thing that I hear often enough to sink in the back of my mind was that the doctor didn't think of me as I was a human. And I still hear that pretty often, and that really breaks my heart for our specialty. I think as a specialty, we should really try to get rid of that within our specialty, where people know ENT doctors are great surgeons. We're so much better than the gastric doctors. We're 50 times better than the orthopedic surgeons because we have smell, taste, speech, hearing, compassion, kindness, and we treat our patients with love and humanity. Questions? My time's up.
Just wondering if you've changed your practice or documentation at all with open notes, and have you had patients, I've had patients like email me, sometimes it's actually very helpful. They're like, hey, I just wanted to let you know, I mentioned I also get headaches this time, can you add that in? And they're not upset, they just want to add it, but have you changed the right notes?
So the question was, have you updated your practice with open notes? For most of us who use big EMR systems, patients have access to them now, and if you use the big one that I use, Epic, how many people use Epic? I'd say 80% of the room, okay. There's something called Care Everywhere in Epic. So when they leave you and they go across town, or I refer them across to a different city or state, they can suck all of that medical information through Care Everywhere back into one medical center. How I've changed that is my outcome survey form. So every patient, every visit gets 2 sheets of paper. One is their current medications from check these medications, make sure they're correct, and hand it back to the front desk. Front desk updates it before the patient comes in the room. The second thing is a how are you doing questionnaire. We don't call it an outcome questionnaire anymore. It's a symptom survey, snot 22, and we take out the snot and change the questions around, but I'm still getting the same data. I put an ACT and asthma control test questionnaire in there too, because quite often it's there. And I pull in a depression survey and mix it in there. And then at the bottom half of that thing, questions you have for your doctor, things that you really want to have addressed today. And it's there at the bottom of that little question. It's on our website. Go to calsinus.com. You can download it. It's in our patient survey. Every visit, every patient does that, and the medical assistants will put that into the patient's note, because that's really the patient's words that go into their note before I see the patient. That's all entered in. If it's really long, we'll actually scan it into the patients, because they'll turn over the opposite side and they'll bring in a summary. We also encourage patients to bring a list of their questions, and I scan that into their chart. So I'll answer their questions and I'll write down the answers. I'll have the staff copy it, return it to the patient. Here you go, here's your answers. See you next week, see you. And then we'll scan that into the media section of their chart. So scanning is a little bit more with open access, because I can't type that fast, but if I write, I'll scan into the chart.
So one thing that I've done to get around the open note stuff and communicate better with patient is my assessment and plan is rarely in the physician format. I basically use the patient instructions box that we have, and everything that is doctor language is broken down where any medical professional should be able to follow it, as well as the patient. I was just curious if you have comments on that. If you think it's a terrible idea, please say so.
No, I think it's a great idea. I think you do want to have, tinnitus, and then you have your little box that shoots off into it. Balance disorder, your little box that shoots off into it. Headaches, your little box, so the patient will see all of this. I think where the patients are really now very much more concerning about this open chart is that they told us something and we didn't put it into the chart. It's not your assessment. Most patients, I have runny nose, take a nasal spray. I've got headaches, go see a neurologist. They get that direct line, but it's the other way where they feel like they told us something and we didn't hear them. And if it's not in their chart, when they open up the chart, they call your staff, and we've been getting that a lot more over the last year, where they say they told us something and it's not in there. When they open up their Apple phone, they're like, it's not there. And you say, well, it is there. And they'll say, where is it? And I say, well, the media section isn't scanned into your phone. I'm going to open the media section of your EMR. I'll take a picture of that, and I'll say, and I'll email this to you. And then they go, oh, it's in my comment section. Did I answer your question? All right, thank you. I'm over time.